Okay, Jess, real question here. How much of your week is just chart review?
Oh, easily half, maybe more if it's a bad documentation week.
Yeah, right. And I think that's the thing people outside of infection prevention don't fully appreciate. So it's not glamorous. It's a lot of clicking through notes at 4 p.m., wondering if what you're looking at is actually a SSI or surgical site infection, or if it's just a really angry drain site.
Ugh, the drain site thing, every time.
Every single time, yeah. So today we're talking about something that could genuinely change that. It's AI-assisted SSI surveillance. And I have to say, when I read the paper, I was equal parts intrigued and ready to ask a lot of hard questions.
Same. It's one of those topics where the attention is intense, but there are so many caveats. And we have a great guest today who has actually done the work to start answering some of those questions.
Yes, we do. We're really excited to have Dr. Salma Abbas joining us today. Dr. Abbas is a board-certified infectious diseases and internal medicine physician. She trained at AJIC University and then did her residency and fellowship at Indiana University and Virginia Commonwealth University. She also picked up a master's in public health along the way.
And she currently leads the infection control and antimicrobial stewardship at Shaukat Khanum Memorial Cancer Hospital and Research Center, which is a Joint Commission accredited cancer center in Pakistan. So she isn't just theorizing about AI from the sidelines. She's actually built the tool, ran the study, and is living with results in clinical practice.
And I think that is exactly the kind of voice that this conversation needs. So, Dr. Abbas, welcome to the show.
Yeah, we're so glad to have you here.
Hey, thank you so much for having me. I'm really excited to be here and to discuss my research project with you guys.
Fantastic. So let's get into that research. The paper, Leveraging Artificial Intelligence for Surgical Site Infection Surveillance, a comparison of 5 large language models, is essentially asking a question that I think a lot of IPs, including myself and Nikki, have started whispering. Can AI do what we do for SSI surveillance, and how close is it?
Yeah, and they didn't just test one model, which I appreciated. Sounds like you put 5 of them head-to-head. You did ChatGPT 4.0, Claude Sonnet 3.7, Mistral, DeepSeek, and Gemini. And I haven't heard of a lot of those and have heard of some of them, but all were reviewed against manual surveillance by an IP nurse.
Yes, it was a retrospective study done at a 60-bed cancer center, 40 abdominal surgery patients, 20 with confirmed SSIs, 20 without, and the models were all working off de-identified clinical notes, labs, and radiology reports using a retrieval augmented generation approach.
Okay, well, that's worth pausing on for a second. So they weren't just prompting a chatbot. They built an actual web application called Detect Infection to feed structured chart data into these models in a standardized way.
And they used NHSN criteria as the ground truth framework, so the models were trained in the same definitions we all use. All 5 models performed in the 90 to 95% accuracy range with kappa scores between 0.8 and 0.9. That's a strong to excellent agreement with the manual review.
Yeah, and one detail that I thought was important here is that infection preventionists' review was also verified by an infectious disease physician. So there's a lot of layers. And Dr. Abbas, I'd love to start the conversation off. Can you talk to us about why you built that extra layer in? And what does that say about how hard SSI adjudication really is, even for humans?
Yeah, sure. As we all know, SSI education is genuinely difficult, even for trained and experienced professionals. And many cases are not that straightforward. You may have borderline imaging findings in some cases, equivocal wound description somewhere, positive cultures that may or may not represent infection, or even documentation that is spread across multiple specialties and multiple clinical encounters. So we added the physician verification because we wanted the reference standard to be as robust as possible. And it also also reflects real world practice in many centers, including ours, where complex cases often end up being discussed collaboratively between IPs, surgeons, and ID physicians rather than just being purely algorithmic decisions.
Absolutely. I mean, that it is a robust investigation when you get one of these. And the IP hit 100% accuracy. So humans are still winning. Woohoo! For now. But there was no statistically significant difference between the IP and the large language models overall. And here's the part that genuinely surprised me. The AI models actually outperformed the IP on deeper infection subtypes.
Which is counterintuitive, right? You'd think the human would catch the subtle stuff, but the IP missed most of the deep incisional and organ space SSIs, likely because those require really thorough chart review across multiple note types. And that's exactly where AI with extended token capacity has an edge.
Yeah, and where the models struggled was superficial SSIs, which are ironically the ones we probably feel the most comfortable catching ourselves. So, why do you think the superficial SSIs were actually harder on the models? Was it because those cases depend on more nuanced bedside wound descriptions, wording variation in notes, the challenges of separating true infection from things like wound dehiscence or irritated drain sites?
Yeah, that's a great question. I think the deeper SSI findings were fascinating precisely because they were counterintuitive. Humans are generally excellent at pattern recognition, but we are also constrained by time, fatigue, and practical limits of chart review. Deep incisional and organ space SSIs often require connecting information from various operative notes, micro results, radiology progress notes, clinical progress notes, discharge summaries, and sometimes admissions and readmissions. The models could process all of this simultaneously without that attention fatigue factor. I think the deeper SSI findings were fascinating precisely because they were counterintuitive. Humans are generally excellent at pattern recognition, but we are also constrained by time, fatigue, and practical limits of chart review. Deep incisional and organ space SSIs often require connecting information from across different kinds of notes, operative notes, micro results, radiology results, progress notes, discharge summaries, and sometimes admissions and readmissions. And the models could process all of this simultaneously without that factor of attention fatigue. In contrast, when you talk about superficial SSIs, these often depend on subtle contextual languages, such as, mention of mild erythema, drain site irritation, or small wound opening. All of these are very specific to the person who's documenting. And these nuances are actually very difficult for AI because they require clinical judgment that goes beyond simple data interpretation and aggregation.
So there's a real lesson in there about where human attention and AI capability actually overlap versus diverge.
Yeah. And let's bring it down to earth for a second, okay? So, because I think if a bedside nurse or a surgical tech is listening to this, the immediate question is probably something like, is AI going to replace the infection preventionist?
Exactly. Dr. Abbas, what is your answer to that?
Well, I would say absolutely not at least in the foreseeable future. Well, because I see these systems as augmentation tools, not replacement tools. And infection prevention is not just about data extraction. It involves clinical reasoning, interdisciplinary communication, understanding surgical workflows, appreciating local practices, and applying nuanced surveillance definitions. What AI can potentially do is reduce the enormous amount of manual chart review and help prioritize high risk areas for human review. But I would say that the IP still remains central to education, interpretation, and program leadership.
So let's talk a little bit more about the AI itself for those of us that don't have like a deep background. What is actually happening when one of these models reviews a chart? Like, what is it doing that's different from a simple keyboard search or keyword search?
What the model is doing is very different from a keyword search. A keyword search might simply identify terms like purulent discharge or abscess, but a large language model is processing relationships between clinical concepts. It can synthesize different timelines, correlate imaging with micro, recognize postoperative complications, and weigh multiple pieces of information together. So that's the major difference.
And to make that even more concrete, what kinds of data were the models actually seeing in your system? Were they reading progress notes, operative notes, microbiology, the imaging, discharge summaries? And did some of these data sources end up being more helpful than others?
In our system, the models reviewed operative notes, progress notes, microdata, imaging reports, discharge summaries, lab information, so all clinically relevant information. And in many cases, radiology and longitudinal progress documentation turned out to be especially important for identifying deeper infections, as we saw in the results of our study.
And the last one I think that comes up a lot in practice, if a model flags something as an SSI and the IP disagrees, who wins? How do you think about that in terms of how this would actually work on the ground?
Well, I would say that the human absolutely wins. These tools should function as a clinical decision support system, not autonomous surveillance authorities. The role of the AI is to assist, but not to override. In practice, I envision these systems acting almost like a second reviewer, flagging cases that may deserve closer scrutiny or help reduce missed cases, particularly the more complex organ space infections, for example.
Okay, let's dig even deeper. One thing I noticed in the models was that all 5 models used a single standardized prompt, and the paper actually acknowledges that this may have limited performance. How do you think about prompt design going into this? And is prompt tuning on your radar for the next phase?
Yeah, in our study, the prompt design was intentionally standardized because we wanted a fair comparison across models. If each model had an individualized prompt engineering, it would have become harder to determine whether the performance differences reflected the models themselves or simply better prompting strategies. So, that said, prompt tuning is absolutely on our radar for future work. I suspect performance, particularly specificity, could improve substantially with more sophisticated prompting, structured reasoning pathways, and integration of these explicit NHS and rule logic.
This is also fascinating to me because I'm always curious about how AI can help us, hopefully not replace us. And one thing I wanted to talk about was the subtype analysis. That really stood out to me. So the IP had a 33% detection rate for organ space SSIs, while most of the large language models hit 100%. You mentioned in the paper that this is likely related to documentation quality and the scope of chart review. Can you walk us through what you think the IP was seeing versus what the model had access to, and whether that's a documentation problem or a surveillance workflow problem? What's going on?
I think that reflected both a documentation issue as well as a workflow issue because the information that identifies these infections was present in the chart, but it was scattered across multiple locations, across different nodes, across different lab results. So, an IP performing manual surveillance may understandably focus on certain key documents or encounter time limitations as well, because they have a busy schedule. The model, meanwhile, could ingest all the available information and text simultaneously. So I don't think the issue was necessarily that the IP lacked expertise. It's that modern EHRs generate enormous amounts of fragmented data, and AI may actually be particularly useful in reconnecting those fragments.
You used an RAG approach to feed the module's clinical data, which is meaningfully different from just pasting notes into the chat window. Can you talk about how you built that pipeline, what the data inputs were, and what you'd need to see before you'd feel confident scaling this to prospective real-time surveillance?
Yeah, so you've mentioned RAG before as well. So it stands for Retrieval Augmented Generation, which is quite a mouthful. So I'll just refer to it as RAG. In simple terms, instead of asking the model to answer from its general training or memory, the system first retrieves relevant pattern-specific information from the EHR, like operative notes, progress notes, microdata, imaging reports, lab data, discharge summaries, so on and so forth, and then presents that information to the model in a structured way. The RAG pipeline was very important because we did not want to simply chat with the chatbot. So the model is not just guessing based on broad medical knowledge, it is being asked to interpret a defined set of clinical data for a specific patient and apply NHS and SSI criteria to that data. And that structure is important because it makes the process more consistent, reproducible, and clinically grounded. That said, there is always the risk that an AI model may generate a response that sounds confident but is not actually supported by the underlying clinical data. For example, it might infer that a patient had an abscess where the imaging only described nonspecific post op fluid, or it may overinterpret a positive drain culture as definitive evidence for an SSI. That's why these tools require safeguards. They should reference the supporting clinical data, follow explicit NHSN logic, and remain subject to human review. So before scaling this to other prospective surveillance activities, I want larger multi-center validation studies, stronger real-time testing, and careful guardrails around false positives, unsupported AI conclusions, and we need to prove consistency with NHSN criteria.
I wanted to ask a question about the false positives because the paper mentions that some of the false positives came from infections present at the time of surgery or from overcalling drain cultures and blood cultures as SSI surveillance. I mean, there's a lot of information going in, so many variables. Can you unpack some of those errors a little bit? Like, what were the models getting wrong conceptually?
The false positives were also very informative. The model sometimes overcalled infections that were already present at the time of surgery or interpreted positive drain cultures and blood cultures too aggressively as evidence of SSI. Conceptually, this reflects a very human problem as well. If we look at our nursing staff, they may sometimes ascribe infections or diagnose SSI based on positive cultures from drains or surgical or other sites like blood. So distinguishing colonization, contamination, or unrelated infections from a true post-operative SSI requires contextual clinical reasoning. So that's a very important key element. The models are very sensitive to infectious signals, but sometimes they lack the restraint or the nuance required by surveillance definitions.
And yeah, the sensitivity of all this, it's just mind-blowing to me, seriously. And there's two things in this paper that Jess and I keep coming back to, and I just want to give you space to expand on both of them. So the first is what I'd call the documentation dependency problem. So the models performed best where the documentation was richest, and they stumbled where it was thin or ambiguous. So that has a real impact on how we think about AI readiness in our institutions. And you've kind of hit on some of that already, but expand on that if you can.
Yeah, as you correctly pointed out, the documentation dependency issue is actually huge. AI systems can only perform as well as the underlying data that they are fed. Rich, structured, detailed documentation improves performance dramatically. On the contrary, sparse or ambiguous notes will only create uncertainty for both humans and models. So, in many ways, studies like this are also indirectly evaluating EHR quality and documentation culture within institutions. AI readiness is not just about buying a model, it's also about having reliable clinical data ecosystems. So, that's what we should all strive for as well.
Man, again, so much to think about with all of this. And I think everybody's probably wondering about privacy because whenever people hear AI plus chart review, I think that's where the minds go immediately. And you de-identified the data and referenced HIPAA safe harbor methods in the paper. What did that process actually look like, and how important is trust around data handling if these tools are going to be adopted?
Yeah, privacy and trust are absolutely central. We use de identification approaches consistent with HIPAA safe harbor principles, removing direct patient identifiers before data processing. But beyond technical de identification, institutional trust matters enormously. Clinicians and patients need confidence that these systems are secure, transparent, and being used responsibly. Because without this trust, adoption will be very difficult, regardless of technical expertise or performance.
The second one is something I think has been underappreciated in the AI for IP conversation, which is equity and scalability. You built this tool in a resource context where IP staffing looks very different than it might in a large U.S. academic medical center. What does it mean for global infection prevention if tools like this actually work? And what would need to be true for them to be deployable broadly?
I'm really glad you asked this question. This is actually one of the parts of the project I am most excited about. Generally, when people hear about this work and they hear that this was done in Pakistan, they might assume that we are operating in a very limited digital environment. But Shaukat Khanum Memorial Trust, it's actually a very large and growing healthcare system with 2 tertiary care cancer centers. And we are about to open a third one soon, later this year, with strong infection prevention infrastructure and fully integrated homegrown EHR. That's important because it means that the workflow challenges we're addressing are actually very similar to those seen in large US academic medical centers, such as huge volumes of documentation, data fragmentation, limited IP bandwidth. Our health record platform, interestingly, is also being used by multiple other hospitals in Pakistan, which means that systems like this could potentially scale across broader networks. Our study was intentionally a small pilot study focused on intra-abdominal surgeries to establish feasibility first, and we are now expanding application to patients at both our hospitals and into other surgical populations as well. We'll now be including breast, neurosurgery, orthopedics, head and neck, and urologic surgeries, because we aim to improve generalizability and better understand how these models perform across different SSI subtypes and documentation patterns. So ultimately, I see these tools as a way to extend the reach of infection prevention teams rather than replace them.
It's all fascinating. And Dr. Abbas, this has been such a genuinely interesting conversation. The work you and your team are doing is the kind of rigorous pilot that this field needs before anyone starts replacing IBs with a chatbot.
Agreed. And for our listeners, if you want to dig into the data yourself, we'll have the full article linked in the show notes. It's a quick read, brief report format, and I think you'll find the subtype analysis alone worth your time.
Yeah, I agree. Thank you so much for joining us from halfway around the world. We really, really appreciate it.
My pleasure. Thank you so much for having me. This field is moving incredibly quickly. And I think what's most important is that we approach it thoughtfully and rigorously. AI in infection prevention has enormous potential, but only if we remain grounded in clinical reality, surveillance science, and patient safety. Thank you.
Absolutely.
And on that note, we'll leave you with this. Apparently, AI can now detect deep in organ space SSI with 100% accuracy.
Yeah, but it still can't figure out if that drain culture is clinically significant.
So the IP job is safe for now.
Yeah, for now. And that's a wrap.
Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
AJIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Jean Brandt at AJIC and APIC staff, Rebecca Bartles, Ria Gupta, and Bobby Gulshan. We work in partnership with Human Factor and audio techs Blake Althan and Carolyn Schneer. To hear other AJIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.